All right. Well, thank you everyone for coming. We'll get started. An hour is a tight timeline here, but I hope that we can accomplish that. So welcome to our community meeting today. My name is Sandra Roosh, and I am the Quality Director and a registered nurse at Brookings Health System. Today we will be discussing the opioid crisis and how to work upstream to conquer this crisis. Today's forum was spurred from a quality improvement project at the Brookings Health System while working in conjunction with the South Dakota Association of Healthcare Organizations and the Compass Hospital Improvement Innovation Network. Through the Compass Network, we learned that rural communities were having great benefit in hosting community meetings such as this. We hope today's forum has the same outcome here in Brookings. We appreciate you for attending our meeting today. We know that this epidemic has multiple moving pieces and cannot be addressed from just one single angle. Today we will be looking at the opioid epidemic from a three-pronged approach, starting with upstream prevention and appropriate prescribing, then looking at addiction treatment and relapse prevention, and finally looking at diversion prevention and medication disposal. We are grateful to have our panelists here with us today. These professionals represent a diverse background, and all of these professionals have seen firsthand the impact of opioid epidemic here in Brookings. The panelists have insight to community resources helpful in combating this epidemic. At this time, I'll ask each panelist to briefly introduce themselves. You'll have to push the button just to talk.
My name is Connor Toffey. I'm a dentist in town here.
I'm Lori Kauser. I'm a pharmacist at Hy-Vee.
Robin Ers. I'm with East Central Behavioral Health.
I'm Terry Nesvold. I'm the Brookings County State's Attorney.
Bart Sweevy, Jail Administrator of Brookings County Jail.
Scott Hawks, Special Agent with the South Dakota Division of Criminal Investigation.
I'm Jill Ayers. I'm a small animal veterinarian in the community.
Rick Heeb, Family Practice and County Coroner.
Thank you for being here today, panelists. As an audience member, if you haven't already done so, please write any burning questions down for the moderator to ask the panelists toward the end of our time together. But before we get to the panel discussion, I wanted to provide the community a bit more background on this topic. So let's start with upstream prevention. So who here has heard of the upstream story? Raise your hand. All right, well, it's always fun sharing this story with someone for the first time. The upstream story goes like this. In a small town, a group of fishermen gathered down the river. Not long after they got there, a child came floating down the river, calling for help. One of the fishermen on the shore quickly dived in and pulled out that child. Minutes later, another child came, and then another, and then another. And many more children were coming down the river. Soon everyone was diving in and dragging children to the shore, then jumping back in to save as many as they could. One fisherman grabbed a boat in hopes of rescuing even more children at one time. In the midst of all this frenzy, one group was seen walking away. Her colleagues were irate. How could she leave when there are so many children to save? After long hours, and to everyone's relief, the flow of children stopped and the group could finally catch their breath. At that moment, their colleagues came back. They turned her angrily and shouted, "How could you have walked off when we needed everyone here to save the children?" She replied, "It occurred to me that someone ought to go upstream and find out why so many kids were falling into the river. What I found out is that the old wooden bridge had several planks missing, and when some children tried to jump over the gap, they couldn't make it and fell through into the river. So I got someone to fix the bridge." We start off today's discussion with this story to highlight our initial approach to combating the opiate crisis here in Brookings. By focusing on prevention of opioid use disorder, we are preventing people from falling into the river of opioid use disorder in the first place. Keep in mind as we go through this information today. I'd like to start with this timeline as it really highlights how this epidemic arose. In the 1950s and 70s, oxycodone became widely available. At this time, the World Health Organization and several other associations and organizations dismissed the belief that morphine was addictive. And then the Controlled Substance Act was passed, and finally the war on drugs was occurring. In the 1980s, we had opioid phobia, and it was a concern for physicians and prescribers on how to use opioids, and there was a fear of addiction and other side effects from their use. During this time, some prescribers explored the use of prescription opioids to treat pain in non-terminal illnesses. Then came the 1990s. The U.S. saw the undertreatment of pain due to successful lobbying for increased use of opioids. Physicians expanded treatment of pain with new opioids and that came to the market, and finally marketing efforts were successful with pharmaceutical companies directly marketing to healthcare providers. In the turn of the 20th century, pain was viewed as the fifth vital sign, and opiate prescribing spiked. I'd like to also add, with government agencies such as the Centers for Medicare and Medicaid, we've added questions of how your pain was controlled to patient experience surveys, so there was additional pressure from CMS in talking about this pain issue. The misuse of opioids quadrupled in just under 10 years. Research began to find abuse determinants formulations due to this spike. Now, I start with this timeline when discussing the crisis because it truly shows that not only big pharma or insurance companies are to blame, but everyone in healthcare contributed to this epidemic. Therefore, it is our job to help fix this. Here's some statistics for us. Drug overdose is currently the leading cause of accidental death in the United States, with opioid addiction truly fueling this epidemic. The number of prescription pain relievers quadrupled from 1999 to 2010. In 2015, more than 15 million people were using prescription drugs non-medically, and 5.1 million were pain relievers. In 2012, over 259 million prescriptions were written for opioids. That is enough for every adult over the age of 18 in the United States to receive a 30-day supply of opioids. Every adult. 4 in 5 heroin users started out misusing prescription painkillers. This graphic is very powerful, and it shows how someone may go from using a prescription opioid to using heroin. So let's say your friend goes in for a sports injury, and it started out on as needed. They needed to take Vicodin or hydrocodone. They were taking this as directed, but it didn't seem to be enough for the pain. So then they go back and get a stronger medication that has Tylenol in it as well. This is still not enough to dull the pain, so they go back to get something stronger and end up with Oxycontin as a long-acting opioid that is taken twice a day, and they are still not seeing that pain relief that they desire. Still, this is not providing the relief they need, and they go back to their prescriber. The prescriber says that they will not add anything more to your friend's medication regimen. Due to the pain and possibly some misuse, your friends ask their family and their friends and their colleagues if they can purchase some leftovers. Then continues the need of medication to prevent withdrawal and goes to the streets to purchase the medication. On the street, Oxycontin is currently selling for over $80 a tablet, and they can sell for $50 to $80 actually. Well, why would they pay for over $300 a day when they could use heroin at just $15 a bag? And that would last them for a couple days. Given the pricing, this is how someone might end up using heroin. Additionally, there are several incidents where heroin is laced with a much deadlier drug, such as carfentanil or some other agent. Truly a scary situation. This photo, Bart provided me with this photo, and I think it's truly impactful to see the different amount of doses in heroin, fentanyl, and carfentanil. Carfentanil is 100 times more lethal than heroin, and it just takes a slight dusting to encounter a dusting where you would reach deadly amounts in your system. So this is not only deadly to the person who's trying to take it for their addiction, but us as healthcare providers or law enforcement or those in the community trying to help. On the screen, you'll see data from the South Dakota Board of Pharmacy and the Prescription Drug Monitoring Program, known in short as the PDMP. This originated when a bill was passed by the South Dakota legislature and signed into law by the governor during the 2010 legislative session. The purpose was to improve patient care by providing providers and pharmacists with controlled substance dispensing history for their patients. An additional goal is to reduce drug diversion and inappropriate use of controlled substances by assisting in the investigation of specific cases. Records are saved in the PDMP for up to 3 years. 49 states have the PDMP in place. The only state that does not is Missouri, and they are working on a county-by-county basis to get into compliance with those gold standard recommendations. Any person who has a license to prescribe or dispense any controlled drug or substance within the state of South Dakota must register with the program. However, veterinarians are exempt. So, for example, for the month of May, there were over 1 million pills of the Vicodin hydrocodone Lortab prescribed to South Dakota residents in just 1 month. Side effects from opioid are common, highlighted in red. Typically, constipation, sleepiness, dizziness, confusion are the most common, and nausea and vomiting, dry mouth, occurring in some people. But there's other side effects to keep in mind, and one of them is sensitivity to pain. The longer a patient takes an opioid, the more pain receptors come up, and therefore the more opioid is needed to decrease the pain. For that reason, we should only use opioids for short-term use unless the patient is treating for cancer pain or end-of-life pain. Note that each day more than 1,000 people are treated in our emergency departments for not using prescription opioids as directed. Should a patient taking a chronic opioid experience decreased breathing or unconsciousness, we should call 911 immediately. One of the surprising statistics that I came upon in related to opioid hospitalizations is the demographic. The most common was a female over 65 years of age living in a urban area and in low income. After thinking about this, it does make sense. These women likely started on this medication 10 to 20 years ago when it was believed to be safe and could have some other factors affecting their use, such as loss of a spouse, a family member, or a lack of nearby family. So it's just not our young men who are at risk of opioid-related issues. Yes, they're still at high risk of death, but we need to be thinking about all patients here. No one is immune from this. Here are our opioid overdose signs. These are just side effects that are really enhanced. When should you call 911? If they have small pupils, weak or droopy muscles, slurred speech, loss of consciousness, slow or shallow breathing, pale face, purple fingernails, and lips. All of these can be sign of an opioid overdose. If you're unsure, call 911. Better be safe than to lose someone you love. And Narcan is now more readily accessible than ever. We can get it at Hy-Vee Walmart and then by prescription at Lewis & Brothers pharmacies. And the next slide, please. This graph shows that opioid illegal deaths have increased since 1999. We are now seeing a spike in heroin deaths since 2010. And as we discussed on the previous slide, that is due to 80% of new heroin users starting out on prescription opioids. So why the word guardianship? We want to talk about the non-medication options such as physical therapy that can help with back pain, acupuncture, chiropractic care, injection therapies, biofeedback, and is best paired with other medication or cognitive behavioral therapy, mental health counseling, those types of interventions. And even at the health system, we recently launched our aromatherapy program on an inpatient care as another method to holistically treat pain. We want to make sure that we're using non-opioid medications such as Tylenol or anti-inflammatories such as Aleve or ibuprofen. Anticonvulsants can help with certain types of pain. Antidepressant medications can help with neuropathic pain. But when we are starting opioids, it is very important that we start very low and that we increase very slowly. And at each visit, it should be decreased in dose and should be considered in alternatives to treatment. We are focusing from the 0 to 10 pain scale more towards the comfort and functionality goals. Comfort can be thought of as ease from constraint of distress. It's important to discuss with the patient that they may never be free of pain. Frame the discussion in a way that says we want you to be comfortable and be able to tolerate your pain. Additionally, by discussing comfort, we can pick up any concerning side effects from these medications while minimizing them, as patients tend to use less medication when comfort rather than pain is discussed. Functionality is another key way to look at pain and opioid use. Functionality will inform healthcare providers on how well the patient is doing and catch potential side effects, such as drowsiness or confusion. If functionality changes, consider functionality in two ways. Can you do the things you need to do, such as getting dressed or walking to the mailbox? Or can you do the things that you want to do, such as attending a child's soccer game or gardening? By focusing on comfort and functionality, patients can create goals of what they want to do and be able to do when their pain is decreased. I will now welcome to the I will now turn it over to our moderator, Dr. Keel.
All right, thank you, Sandra. I'm really excited to be here to moderate this wonderful panel discussion today. We have about 45 minutes to walk through the 3 pillars and some questions about how this epidemic is impacting our community. Panelists, thank you so much for being here. I want to remind all of you that you all have wonderful experiences to share, so if you can keep your remarks to about 3 to 5 minutes, we should be able to get through everyone and make sure that everyone's voices are heard. And we had a couple of questions from the audience that we'll address at the end as well. So at the beginning, Sandra had talked a little bit about the 3 pillars for opioid guardianship. And so we thought it would be helpful to talk about each of those 3 pillars in turn in our community here in Brookings. So the first pillar was upstream prevention and appropriate prescribing. And Dr. Rakib has volunteered to talk a little bit about that perspective in our community. Dr. Heeb, about 3 to 5 minutes.
Thank you. It'll probably be less than that.
Concision is great.
Obviously, the best thing is to not make somebody an addict. We figured that out kind of retrospectively, which is unfortunate. There's a lot of things going on, and I'll just mention a few things that we're doing. I won't get into the PDMP right now, but we're monitoring much more closely what we're doing. One of the things that has been discussed and is now in place is that initial prescriptions are going to be 1-week scripts, and then reevaluation after that. In the past, we've had problems with people coming back from a major surgery with a month's worth of medication. The family practice and internal medicine doctors have been blamed for most of this because we do the most prescriptions. We see the most people. Part of that is probably true, but we get a lot of people that come back and say, hey, I want my meds refilled because I need these. Unfortunately, we've had recent research that has shown that you can become addicted in about a week, start getting that dependence. So we're monitoring much more closely what we're doing right now. The PDMP watches that. There's oversight. And I think what we want to do is we want to make sure that we can put the people on appropriate pain medication, but then get them off and wean them to something else. One of our problems that we're having right now is that even though there are different medications on the market, we're kind of limited. Some of the meds that we used to have that were milder narcotics, like Darvocet, Darvon, Tylenol number 3, have been poo-pooed and either taken off the market or not being used anymore, which in my mind is kind of a shame. You know, if I want to use a narcotic, I want to use the mildest one I can use to treat that patient. We have a lot of regulatory issues that are going on the federal level that are making a lot of problems for us. I'm sure some of my other police officer friends can testify to that. But I think there's a lot going on. There's a lot of education going on. Actually, that's been going on for several years now in the primary care world. Which is good because the federal government says we need to be educated. Well, we're already on top of that. I've already been to 2 seminars in the last year, and I think that's a good thing to do. Thank you.
Great. So our second pillar is addiction treatment and relapse prevention, and 2 of our panelists are going to speak toward that second pillar, and the first is Terry Nesvold.
Well, the first part about treatment is we have to get rid of the stigma. We have very many functioning addicts, and when they're put on the prescription, they're getting it from a doctor, they think it's safe, and then it spirals into where they cannot control it. Then they go bargain shopping, then they are going to the vet, to the dentist. So if we can get over the stigma, because drug addiction is a disease, and we need to get over that stigma and have people reach out to the practitioners that we have in the community and the service providers that we have. I have a natural high for drug court. Drug court works. We have individuals in drug court who use prescription medication, and they have fallen into the abyss of their addiction and need help. Drug court is supervised, just the most supervised probation you can have. But we don't allow drug dealers in. It's a safe environment for our individuals to get the help they need. They are monitored 24/7. We know every single thing that's going on in their lives. And a lot of times they've been into an inpatient treatment facility and they just haven't had that kind of supervision. Once they leave, they leave. The goals for drug court is to get them a job, budgeting, management. We expect relapses, but we're there for them, and we have counselors and treatments to get them over the stigma and over the idea that they can never get rid of their addiction. They just have to show up, try, and be honest. You come to court every Thursday, we talk about your week. We can get the stigma out of it. We can get the addiction. There's so much shame in having an addiction in our country. The other issue with relapse is if you are in your grandma's medicine cabinet and there's a pill bottle and you take 1 or 2 pills, those pills aren't oftentimes being taken by the individual that is seeing them. They're being sold. And they're being sold for $20 on the street. And it's a real issue with the SDSU campus. But as mentioned by Sandra, once you say, we're bargain shoppers in this country, once you see that you can buy a pill for $50, oh, I can buy a bag of heroin for $15. And the heroin on the street, which I'm sure Scott can attest to even more detail, is so pure, so cheap, it's an easy fix for somebody that doesn't or has been stopped forum shopping. So the basics is we just have to get people out there and show them that we're willing to help them. We've got the programs, but we have to stop the forum shopping, we have to stop the selling of the pills, and we have to stop the stigma. And I think if we can do those things, we can really help the individuals get over the addiction. And so if you have family members, if there's people that you think have problems, I would love to talk to you and give you programs that they can go to and reach out. I don't want them to go out and get a felony charge so that they have to come to drug court, because unfortunately you need to be in the criminal justice system. But I want to be able to give them these other outlets that we have through the drug court system.
Great, thank you. And our second panelist, who's going to speak a little bit more about that second pillar of addiction treatment and relapse prevention, is Robin from East Central Behavioral Health.
Good afternoon. Can you hear me? I'm not used to speaking with a mic. I yell loud enough without. I'll piggyback a little bit on Terry's comments regarding drug court. Unfortunately, or fortunately, however you choose to view it, I've been in this field long enough to know that back in the day, our standard operating procedure was to take someone suffering with a drug or alcohol addiction and send them away to a 30-day stay somewhere, and they were going to get cured and they were going to come back into the community. Over the decades, that's been proven to not be the most efficient, effective way to address those individuals' concerns. And the drug court has addressed a number of those issues. The longevity of connection is key. A drug court participant is going to be involved for a minimum of 18 months, I would say, if not 2 years. You know, and that's absolutely key. They're allowed to stay in their home community. They're allowed to stay with their family if they have that, with their job, so on and so forth, and get helps in other ways if they need them. But the key component is that they're addressing the issues that they have in the community in which they live, and that's most important. And we're seeing a significant increase in success and sobriety with that. As Terry noted, there are relapses, and that happens. That's just a course of life. But to have that support system within the community makes all the difference in the world versus the way we used to do it, where we sent someone away and then they came back, and we haven't addressed those issues. One of the frightening things that I see in what we're dealing with in the treatment and mental health arena is the influx of our young people becoming involved. I can't recall in my aged years seeing so many young people come in with such horrific addictions at such an early age. I was an extremely strong advocate for FASD prevention. One of my caveats is the prevention of a totally innocent person being subjected to an addiction when they have no choice and no voice. We had the New Start program in Sioux Falls where we house women so that their child can be born safely and without those maladies. And we're seeing 12, 13, 14-year-olds come in. When you talk about the access to the drugs, Where do individuals get them? About 30% get them with their own script. Another 10, 15% are going to get them from friends. They're going to trade, they're going to swap, so on and so forth. And another 30% are going to get them off the street. And that's where you get that piece where they're selling the oxy and the hydro for $50 to $80 a pill. And we're seeing, excuse me, we're seeing our young people access grandma and grandpa's medicine cabinet. And I can speak as a grandma and an aged individual. I can't always remember how many pills I have left if I have a prescription. And so you don't think about that and you don't see the links. And that's where these young people are getting them. It's extremely frightening. They don't know what they're stepping into, and the consequences are severe. You've also seen in the community of late, I think, which is really alarming and perplexing and scary to me, an increase in violence. I can't remember a time in the community where we've had so much in relation to violent assaults, activity, and I would venture to say 9 times out of 10, it's around accessing either the money or the drugs themselves. But there are things in place, and I think this is a great opportunity. What needs to happen is weaving all of these various entities together to create that safety net so that anyone in the community knows they can go and they can reach a person here, 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 or here, and we're going to work together to have that net below them and work towards their health and safety, as well as the communities.
Great, thank you so much. So the third pillar that we want to address in terms of opioid guardianship is diversion, prevention, and medication disposal. And 2 panelists are going to speak toward that pillar as well. The first is Bart from the Brookings County Sheriff's Office. Bart.
Helps if I turn the mic on. I wanted to just briefly tell you about disposal of medication. We've got couple needs as to why we need to properly dispose of the medication. We've got people who may, someone who the medication was not prescribed to. Let's say that, like there's been some examples already, you got some medicine in the cabinet, somebody else comes across that medication. That medication could be stolen or taken by the person that discovers it. And then they're selling it out on the street or using it for themselves. Also, another reason is some of our elderly people may have trouble distinguishing between which medications they're still on or what they're not supposed to be on. How many, don't need a show of hands, but think of sometimes when you get medication prescribed to you, even like an antibiotic, and you come to the thing, oh, gee, did I take that or didn't I take it? It's easy to become confused. So when we're looking at the elderly people, they can get even more confused, and they may have tons of medication that, that they've got to be on, and it becomes confusing for them. So better for that medication that they're not supposed to be on to get it in and properly disposed of. Now, there's some different ways to dispose of it properly, and that includes, disposing it of, in cat litter or things like that. Some examples too of like coffee grounds or dirt, and just to get it mixed in with something that's undesirable and tossing it in the trash. We also have locations where it can be disposed of in proper safety containers. Our sheriff's office has one of these in our front lobby. That's accessible 24 hours a day. It's a locked box. So it sort of works like a mailbox where you can't get back into it and drag anything out of it. We're working with currently with the DEA, who will be collecting what we take in twice a year. We do ask that if you do bring anything into the sheriff's office to not bring any needles in. We can't dispose of that. We're just after medication for disposal. We are also planning on being part of the Drug Take Back, which is a national day, and the next Drug Take Back is scheduled for October 27th. And we plan on being a part of that unless some of the pharmacies are going to be hopping on board with that here in town. which could be a possibility. We just need those pharmacies to take that effort to get on board with that same program. One more thing, how does this help us by properly disposing of this? And we've touched on this a couple of times already. This reduces crime rate. There's just the illegal drugs is not our problem with people that we've got incarcerated. We've got the opioid problems where they're getting hooked on these other things too, like we've talked about, which is leading into the illegal drugs. So we've got to get rid of the access that they've got to these opioid medications.
Great, thank you so much. Our second panelist, who's going to speak a little bit about that third pillar of diversion prevention and medication disposal, is Scott Hawks with the South Dakota Division of Criminal Investigation. Scott.
Thank you. I guess I would just start off with the law enforcement end of it. Talking about drug court and how it has been in the community for 2 years now. 2 years. So I've been here about 5 years in Brookings as a DCI agent, and when I first started, our biggest problem was probably the repeat offenders. I think Terry could agree to that. We were seeing people over and over and over, and that was more of the possession end of it with not only the opioids, but the meth and the marijuana as well. And now with the drug court, we see less and less of the repeat offenders, which helps with the amount of drugs on the street. We don't see the same possession problems. And with the dealers, when we focus on the dealers, obviously dealers aren't allowed to go to drug court, and they get locked up, which in turn helps the diversion problem, the possession problem, and we don't see as much of that anymore in Brookings. Thought I'd also just touch real quick on the dark web, and for the younger generation was brought up with the access to the internet and the anonymity of the dark web. The younger generation we have seen where they are utilizing the Postal Service, UPS, FedEx, where they can go online, create these false identities using the dark web, and they can purchase absolutely anything they want to. Price-wise, it's not a lot different than buying it from the street, but they feel it's safer. They're not doing a hand-to-hand transaction with somebody, and they just go online, purchase it, and it shows up at their doorstep. As a community, that is something to look for. If packages showing up, we work very closely with the Postal Service and try and focus our efforts on some of the dark web, drugs being sent. There's a lot of it that comes from overseas, and there are steps in place to try and prevent some of that from getting into our community.
Great, thank you. All right, so after talking about each of those three pillars for opioid guardianship, now we want to turn to a little bit more of a local flavor to this particular issue. And so I'm going to ask some questions of our remaining panelists about the specific community of Brookings and kind of what's going on and what can we do as a community. So my first question is to describe just generally your link to opioids in this community, and we're going to start off with Dr. Jill Ayers.
Primarily as a practicing small animal veterinarian, we do use opioids. Mostly those are given in an injectable form during operative procedures, post-operative pain management, and acutely sometimes for acute pain. Most of the time we try to manage pain with medications that are not opioids for our patients. However, there are some situations, end-of-life care, cancer, chronic pain issues, or a few other issues where the opioids can be very helpful in keeping our patients comfortable during convalescence or sometimes during end-of-life care. The issue that we have is not that our patients abuse the drug, it's that our owners of the patients abuse the drugs, and we do have to be very cognizant of that. The FDA just came out with a statement a couple days ago. The AVMA, the American Veterinary Medical Association, is very aware of this risk. And so veterinarians, this is certainly a topic of conversation of veterinarians. I did find a very interesting study that was conducted recently in Colorado And one of the interesting pieces of this study was that 13% of veterinarians have been aware of pet owners who have intentionally hurt their animals in order to acquire narcotics. So it is a situation, unfortunately, it's a situation that I have seen. And, you know, there are lots of things that we try to do to prevent diversion of these drugs into the community, either by the owners themselves or the concern that they might be acquiring them and selling them. Different states, most of the states do not have to, veterinarians don't have to follow the dispensing regulations, and South Dakota is one of those states. I think that's probably going to change because of these concerns. You know, we try to dispense drugs that are not narcotics as much as possible. When we do dispense narcotics, we are very, we have to record them, of course, for the, because they're a scheduled drug, but we also record them in the patient's chart. We record the amount that was dispensed, the dosing information, and then when owners call for refills, if we look back on that and know that they couldn't have consumed all of them, or if we get we oftentimes get these calls like, oh yeah, I left that bottle at the lake, or we went on vacation and now I don't have it and I need more. You know, if that happens once, we'll fill it. When it happens more than once, we generally contact the authorities and express that we have a concern that there might be a diversion going on. And we do sometimes see people who come in who we've not dispensed it to them before, but they come in with very specific information, you know, like they'll come in and say, well, I don't think that really works. Do you have something else that would work? Like maybe, and they will mention a drug name, and that's just such a red flag. And in part because, as a general rule, the drugs that we use in small animal medicine, they're extra label use. They're not drugs that are tested or licensed for the use in animals. We are able as veterinarians to use them, but there isn't a lot of evidence that they're the most efficacious drugs. And so when owners request them, we're immediately suspicious that it's an owner request and not a request in the light of trying to keep the pet comfortable. So, you know, I think this is going to be an evolving field. I think as veterinarians, we do play a role in trying to keep these things off the street. And I think going forward, we're going to find more and more regulations coming down the pike for us to follow to try to prevent them from falling into the hands where they're abused by humans.
Thank you so much, Dr. Ayers. Dr. Hoppy, if you could speak a little bit about your connection to opioids in our community of Brookings, please.
Well, I don't know. You can't really think about dentists without thinking of pain. We are targets from the local, you know, people that want those things. People come in, they will, you know, they present with some pain. We prescribe some treatment. I've been giving out prescriptions in the past. Appoint the patient for the following for some time, and then they simply don't show up until the prescription runs out, and then, you know, you've violated your license, essentially. So, you know, what I've been taught lately is a lot of focusing on, let's say, the first pillar, dental pain modalities that we use to treat dental pain. And pain rises from things like trauma, muscle joint stress, neuralgia, just to name a few of the things. We tried it. It's important for us to get a good medical history and a history of the condition that the patient has, the medications that they have on board, and to get a good, accurate history and diagnosis of the problem that the patient is having. And that takes some time sometimes for some dentists just to be able to work in the profession and learn what's really going on. Also, after that, you have to be able to try to create a really good treatment plan for the patient, and or be able to refer the person and be able to treat it, or be able to refer it to a person that can treat the problem appropriately. And always trying to work within or towards something called a therapeutic endpoint, where you're simply not prescribing or masking something. You're trying to get to the end and solve the problem. Pre-medicating a patient for procedures. Sometimes we have pain after procedures. They complain their face hurts. We pre-medicating patients prior to procedures with antibiotics or pain medications, steroids or non-steroidal anti-inflammatory drugs. Those decrease the post-operative pain. It decreases the amount of stress that the person has and decreases the amount of their reliance on other drugs, like opioids. Um, we also have many types of local anesthetics. We have short-acting, 15, 20-minute local anesthetics. We've got lidocaine, gets you 2 hours, maybe 3. Or we've got Duranest, longer-lasting anesthetics that'll get you 12 hours of anesthesia. So the longer you don't have to feel it, the less drugs you need. And while you're on that long-acting anesthetic, you're also able to start getting some use out of the non-steroidal anti-inflammatories or the steroids that you're taking. Sometimes just reducing, using sedatives preoperatively, if your dentist is licensed to do so in this state now, you can reduce anxiety before they get in the chair so that they don't need those drugs afterwards. Also, using when we have to use drugs, we want to use drugs that have a safe profile. Drugs as simple as clove oil, heat, cold, are commonly used to treat pain. Acetaminophen, steroidal and non-steroidal anti-inflammatory medications are commonly prescribed for pain medications for acute and chronic dental pain. And while opioid medications, in my practice, are seldom used, because I simply just don't use them. I've had a DEA license since I started practicing in 1988, and I just simply don't like to use them because people get them and then that's what they want. So I want them to be treated to get rid of the pain. And I think that everybody else in my dental community feels the same. When I do prescribe those, though, I also prescribe a limited number. What I think will be necessary to get the patient through some type of urgent time while other medications take over or while the healing process goes on. So,
Thank you, Dr. Huffey. Just for the sake of time, we're going to move on to the next question, but thank you. So our next question is for Lori Kauser. If you could share a story of when opioids were concerning to you in your practice at Hy-Vee.
I could tell a number of stories, but the one that is probably the most recent, we see people coming in with written prescriptions and they try to alter them. We had one from the emergency room here in town, and it was just written for Celebrex, which is a non-steroidal anti-inflammatory. It's not controlled. But the patient wrote in a hydrocodone prescription on there. A lot of things that have been coming down the pipeline and that we're using a lot to help avoid these situations is like electronic prescribing, and that's where the provider can send the prescription from their computer to ours. The patient doesn't have anything in hand to try to change a prescription or divert it. So that's been a wonderful tool, and that's helping out a lot. The PDMP has been mentioned a lot. That's the tool that providers and pharmacists can use to look to see patterns where they've gotten prescriptions filled. And it hasn't been mentioned yet, but we are linked to other states as well. So if I go in and search for somebody, I can see the surrounding states if they've filled anything. We just usually target or really look at people that we're not familiar with, or they're from a long ways away, or the doctor prescribing or the provider is from a long distance. We also get leads sometimes from the Board of Pharmacies for people who are diverting. So a lot of times we'll have names to watch for. So that's been very helpful. We also, if we see a prescription that's altered, and we will definitely call right away. Problem is some of these people are smart and they try to come in after hours or when we can't get a hold of the provider. So as a pharmacist, I would just reject that prescription. Because it is legally their prescription, they can ask for it back. If that happens, we alert all the pharmacies within a certain radius, and we would call the provider the next day. But you certainly see a lot of that. I mean, when you have a written prescription, a lot of people will, if it's written for 10 tablets, they'll change that to a 40. Some are very good. Some do get through with them, but when you start looking for that stuff, a trained eye helps to catch that stuff. But that's the biggest thing is we've had a lot of success with the PDMP.
Great, thank you so much, Lori. All right, our next question is about what advice would you share with someone who is concerned about a loved one who might be misusing opioids? And Robin has volunteered to talk a little bit about that particular question.
Okay. I must have been in an altered state when I volunteered. I think we see a lot of that in the community where, as parents and grandparents, you might see something, but then it's, oh, no, and we talk ourselves out of it. It's quite common because we don't realize the magnitude of this issue in this community. We think we are shielded, and I believe, was it Scott brought up the dark web? One of the things that I find, and again, I said I was old, our young people are so adept and so quick to catch on to the social media piece and connect and access things, and I'm slow. I'm not the only one that's slow, so we can't plead ignorance anymore. I think you've seen through a multitude of stories the impact that this is having on our community. We always used to joke back in the day when I first started in this field that it took 10 or 15 years for the hot topic to hit here because we're kind of slow and we're in the middle and we're protected. We don't have that cushion anymore. We don't. And if we don't get in front of it, we're going to get run over. And fortunately, I feel in a lot of ways we're getting run over. Bart, in our jail system, our UJS system, our treatment capacity, we don't have it where it needs to be to deal with the issues that our citizens are coming to us with. So how do we solve these problems? I guess the bottom line is, if you think it, talk about it. If you have a question and you don't know, ask. There's a multitude of resources in the community. I don't know, I'm just not feeling right about this behavior. What do you think? Tap into those people and get that assessed as quickly as possible. We can no longer push this under the rug as much as we'd like to.
Thank you. And I see Julia is bringing up, we do have a handout in the back that has the Brookings Area Substance Abuse Treatment Resource Guide. So please, if you do have a loved one who you're concerned might be misusing opioids, please do pick up that handout and feel free to ask. Any of our panelists, I think, would be more than happy to talk with you one-on-one as well after the panel is over. Our last question before we get to a couple of audience questions is what resources are offered in Brookings to try to combat this issue? And Scott, if you would please speak to that question.
The handout is available for everybody to take with them today. As you can see, there are a number of places in our community, surrounding our community. Lots of professionals and not even professionals, just sometimes just talking to a neighbor, talking to a friend is all it takes to understand that, hey, this might be me, I might have a problem with this, and it doesn't have to be a law enforcement thing by any means. There are a number of people that everybody can talk to, churches, the Narcotics Anonymous, the counseling services. We're fortunate in our community that we have a lot of these options out there.
Great, thank you, Scott. So we did have a couple of questions in the 10 minutes that we have remaining to talk a little bit from the audience's perspective, what were questions that they had. And certainly, if audience members, if you have other questions, feel free to stand up after these couple of questions and ask as well. A couple of folks had questions about the availability of Narcan, or the generic, I believe, is naloxone. And so I know Sandra brought this up, I think, in her presentation, but it is available over the counter at Hy-Vee and at Walmart, and then it's available by prescription at Lewis and Brothers Pharmacies. So I just wanted to make sure to highlight that. And then we actually had a really compelling, go ahead, Lori, if you can speak more to that.
I just want to clarify that over the counter really isn't the correct terminology for it. You can't walk in somewhere and just buy it. but it is available through your pharmacist.
Great clarification. Thank you. And then the second question was a pretty personal question, but I'm going to try to generalize it to everyone so that if someone else is in a similar situation, they also can get some insight into this issue. Someone had asked a question about if you have an adult child, right, who you suspect is addicted or maybe has been in addiction treatment, but they're seeing a provider who is continuing to prescribe particular medications. What do you do? So I will open that up to all the panelists, but perhaps Dr. Heeb, you might have some insight on that.
Well, that becomes a little bit of a sticky wicket because of confidentiality, you know. But I think any person that would have that concern could certainly contact the doctor and say, you know, this is what's going on and this is my concern. Please consider that, because oftentimes we have no idea, you know, what the past history is. We can look at how much narcotics a person is using and when they're using them, but beyond that, we may be blind to that situation.
Yeah, and I know this particular question, the person had indicated that they had spoken with the physician and they still were kind of pushing back. So any advice for a concerned mother or parent if you have an adult child who is working with a physician that won't listen?
I'm going to stick my neck out here and say that I would call the administrator of that clinic and talk to the administrator, and then maybe that can be discussed at a different level.
Yeah, that's a great point. I think especially, this person had indicated that their child had been in treatment, so I think they have a pretty solid experience there for moving forward. All right, anyone else have other questions? We still have about 7 minutes left that maybe you didn't write down, or you have burning questions that you want to ask our panelists. Karen is circling, so if you do have a question, please stand up. Sure, that's a great question. Panelists, anybody have some insight on that?
To my knowledge, there is no one. And I've looked at that. On a personal basis, I don't want to touch it because it's, you have to go through all this federal stuff to get certified. And I disagree with that. I think there should be an educational program, but then people should get certified. In our clinic, we've talked about that. But if one person does it, they're going to get overwhelmed. And we need kind of trying to get that together and get a cohesive effort to get 10 people certified in that so that we can do that as part of a practice instead of an entire practice. Because quite frankly, those of you who are involved with this know that if one person does it, that's all they're going to do for the rest of their life, because there is enough trouble in this town.
Mm-hmm. Thank you. Other questions, audience members, they might have? Bart, you want to speak to that? Great question. Thank you. Paramedics as well.
And I would like to bring up through our quality improvement efforts with our Compass HIN that brought us this idea to host this. We are tracking and trending the use of Narcan in the emergency departments as well as pre-hospital. So we have benchmarking for area data, and so that's always interesting to look at and track and trend.
Any other questions? All right, if you can join me in giving our panelists a round of applause, please. And I just wanted to emphasize that both of these handouts, one with the South Dakota prescription drug take-back sites, as well as the other that Julia had brought up with the different treatment resource locations in our community are available on the back table as you leave, and Karen Weber there can direct you to those as needed. And I also wanted to emphasize as well that our panelists are certainly, I think, more than happy to speak one-on-one with folks if you have a specific personal question that you wanted to ask one of our panelists. Thank you so much. Hope you have a great rest of your day.